Today we will be just talking about the very common anomaly, it's a CNS anomaly, that is Holoprosencephaly. And we would, since from the genetics point of view, we will look from the simple to complex inheritance. And it would be of some interest to you also, because definitely the diagnosis is the prenatal thing. So the topic would be covered in the following heads: that will be introduction, subtypes, clinical findings, genetic counseling, and management. So what is holoprosencephaly? Most of us know this. This is the most common malformation of the forebrain in humans, and this is a structural anomaly of the brain which results from the failed or incomplete forebrain division in the 3rd to 4th week of gestation, which then normally happens in that period. So the prosencephalon incompletely cleaves into right and left hemisphere and deep brain structures and the olfactory and the optic bulbs and tracts. This is the most common forebrain defect in humans, with a prevalence of about 1 in 250 embryos and about approximately 1 in 10,000 live-born infants. So when we talk about the types, basically it's a continuum from mild to severe. So we'll just discuss on the most severe form is the A-lobar, then the semilobar and the lobar, then we have got some other variants. So in A-lobar holoprosencephaly, then it is a single monoventricle with no separation of the cerebral hemispheres. While in case of semilobar, the left and right frontal and parietal lobes are fused, and I will show you the pictures, and the interhemisphere fissure is only present posteriorly. In the lobar types, which is like a mild one, most of the right and the left cerebral hemispheres and the lateral ventricles are separated, but the frontal lobes, most rostral aspect of the telencephalon, are fused, especially ventrally. So, and there is one more variety, that is middle interhemispheric fusion variant, also known as intencephaly, which is characterized by posterior frontal and parietal lobes, failure of the separation of the posterior frontal and parietal lobes, with varying lack of cleavage of the basal ganglia and thalami, and there is absence of the body of the corpus callosum. However, the genuine splenium of the corpus callosum are there. And one more variety is the septo-preoptic type, which is basically the non-separation is restricted in the septal or the preoptic regions, and this has been described only in some small case series. So other structural serious findings that may occur with HP but not specific to holoprosencephaly may include anomalies of the midline structures. There could be macrocephaly secondary to hydrocephalus, landing of the malformation, neuronal migration anomalies, caudal distances, or abnormal circle of Willis. So there is a spectrum of the craniofacial anomalies which are seen in holoprosencephaly patients, and it affects around 80% of the affected individuals. And the most severe form is the cyclopia, and from cyclopia at one spectrum, at one end of the spectrum, to the normal face on the other end of the spectrum. So coming to the clinical subtypes and the range of the possible clinical findings in these subtypes. So when we talk about the A-lobar HP, which is the most severe form, it is characterized by cyclopia, which is a single eye. Cyclopia is basically single eye or partially divided eye in a single orbit with proboscis above the eye. It could be, and there could be cyclopia without proboscis. There could be ethmocephaly, that is extremely closed spaced eyes but separate orbits with proboscis between the eyes. There could be sebocephaly, that is closely spaced eyes with single nostril nose. Then only closely spaced eyes could be there, anophthalmia or microophthalmia, bilateral cleft lip and depressed nasal bridge of this thing, and relative normal facial appearance in some of the variants which are associated with mutations in Z2 gene. So this is the picture if you see. So what we are finding here that this MRI picture shows this red large midline monoventricle. This is complete holoventricle, there is no separation, with the fusion of the frontal lobes and the midline grey matter structures, that is thalami and the basal ganglia, which is showing this. The blue arrow is pointing towards it. Typically, the corpus callosum and third ventricle are absent in this. The facial features of A-lobar holoprosencephaly includes this cyclopia, which is an eye-like structure, and then there is an overriding nose-like structure, which is called proboscis. So these are the features which are in the most severe spectrum of this. In the slightly less severe form than the semilobar HP, which is characterized with closely spaced eyes, anophthalmia, slant nasal tip, absent nasal septum. There could be bilateral cleft, lip with median process, and midline cleft, or there could be just a relatively normal facial appearance. So this is the picture of the semilobar types. In this MRI shows the fusion of the frontal lobes, but there is some separation. Usually with the presence of the cortex is there, and this is interhemispheric fissure is there. So there is not unlike in a lobar where there is a moroventricle, there is interhemispheric fissure, and besides that, see the picture which is scheduled microcephaly, then we have got closely spaced eyes, depressed nasal bridge, and cleft lip. The lobar type we have got with lobar is more, one of the mild forms, which is associated with the bilateral cleft with median process, closely spaced eyes, depressed bridge, or relatively normal. So this is the picture. The child, if you don't see you don't observe, then it could may pass as a normal face. So MRI here shows the cerebellar hemispace are separated, and these are the arrows which show the separation of these. And there is variable degree of fusion of the midline gray structures. So that is thalami, basal ganglia, and which are fused. And relatively normal facial of the child with lobar HPE, and which is caused by this picture is of the child with the Z2 variant. Then subtle dysmorphism include narrow forehead, which is not very much apparent. Then upslanted palpebral fissures, relatively large ear, relatively depressed nasal bridge, and broad and well-defined filtra. So one of the which is a normal also, with subtle dysmorphic features are there. The other variant is, as I mentioned, the middle interhemispheric fusion, scheduled closely spaced eyes, different nasal bridge, and narrow nasal bridge, with relatively normal facial appearance. Then see this is the middle MIHF, that is middle interhemispheric fusion, and here the facial appearance is usually normal. The other microforms. Microforms are important. Sometimes these are observed in the relative of the proband. We have seen the proband, or when we look closely at the parents or maybe siblings, then we'll find they also have some form which has been otherwise missed. If you only closely observe, find they can have macrocephaly, single central maxillary incisor, closely spaced eyes, anosmia oblique hyponosmia, resulting from the absence of olfactory tracts and bulbs. So, or there could be a broad range of ophthalmologic abnormalities, including ptosis, microcornea, coloboma. These things should be looked when we are examining a proband. So relatives like parents and siblings should be also checked for all these microforms of HPE. There could be sharp, narrow nasal bridge and absence superior labial credula. Associated mid-face region of congenital nasal piriform aperture stenosis. And there could be a developmental delay which of variably present, and pathogenic, and then individual with classic HPE spectral facial features and pathogenic may be seen in the severe. So these are the microforms of HPE, as I say. Premaxillary agenesis is repaired. Here in this child, bilateral cleft lip is repaired. There is abscess of the nasal bone and cartilage with narrow nasal bridge. Then there is a single central maxillary sinus. These are the small like central maxillary. There is a cleft lip. So all these things we have to see. Like this again is a single central maxillary incisor. So these things may be missed if we are not checking carefully. So what are the clinical manifestations of holoprosencephaly? It could vary from developmental delays, seizures, hydrocephalus, NDDs, hypothermic and brain dysfunction, vascular dysfunction, then short session and failure to thrive, feeding difficulties, aspiration pneumonia, and erratic sleep patterns. So when we talk about the life expectancy, then infant with severe form, that is LOR holoprosencephaly, cyclopia, arithmopathy, they generally do not survive beyond 1 week. Approximately 50% of children with LOR die before age 4 to 5 months, and 20% live past 1 year of life. In other forms, in the semilobar and lobar variety, more than 50% of the children they are alive at the age of 12 months. And if generally there is an inverse relation between a normal karyotype and the severity. If the karyotype is normal, then severity is less. And if it is there is an abnormality, then actually there are other involvements and also, so length of survival is also decreased. So amongst, it has been observed that amongst all the survivors, the vision and hearing is apparently normal, and they smile and demonstrate good hearing. The causes is actually, there are various, as the genetics is advancing and more we are getting the more causes, so we are finding it's more of a genetic cause has been elucidated now. Otherwise, it could be environmental, heritable, or multifactorial. So, among the environmental causes, the most common terrorism in the human is known to cause HPE in maternal diabetes mellitus. IDMs have 1% risk, that is almost 200-fold increase compared to the general population for HPE. The other teratogens include alcohol and metabolic acid have been associated with this, although their significance has not been established. So most recently it has been observed that cholesterol role, because ultimately it has been seen that there is a problem with steroid metabolism. So cholesterol lowering agents like statins have been associated with HPE, although causal relationship between the prenatal statin use and HPE has not yet proven, but it has been studied now. So an animal model of the maternal hypocholesterolemia has been shown to cause HPE. Preliminary studies in humans show that the maternal hypocholesterolemia can be associated with HPE in her offsprings. So in the heritable form, it could be chromosomal, molecular, or pathogenic variants in a single gene. So when we talk about that, the chromosome, what are the various chromosomal abnormalities which can be associated with HPE? So it is in about 25 to 50% we find some chromosomal abnormality, and these are not specific. It could be numeric or structural anomalies. And those with HPE and a normal karyotype cannot be distributed. Just based on the craniofacial findings, we cannot distribute that these going to have normal or, but generally there are other organ system involvement in case of the presence of the cytogenetic abnormality. So the numeric abnormalities that which have been associated with HPE include your trisomy 13, 18 and the triploidies. Then in approximately 70% of the individual with trisomy 13, it is HPEC, about 70% with trisomy 13, that is Patau syndrome, and which has a birth prevalence of 1 to 5,000. The defects of the corpus callosum have been reported with trisomy 18, that is Edwards syndrome. So there is various that these are those were the numeric abnormalities given the non-structural. It is structural abnormalities have been reported in almost all the chromosomes, but the most frequent in descending order are the deletions or duplications involving various genes of 13q, 18p, then deletion of the 7th chromosome, duplication of the 3, deletion of the 2, and the deletion of 21. And it has been observed that many of the reasons they harbor the genes which are associated with autosomal dominant form of the non-syndromic form of the HPE. And the significant phenotype variation exists among the individuals with similar cytogenic deletion. So other molecular abnormalities could be copy number variations, which are detected by the chromosome microarray, and it is seen in about 10 to 20% of all individuals with HPE. These CMVs can include loci which are already known to be associated, or as well other loci whose relationship has not been well established so far. So coming to this, then we talk about the single gene disorders associated with the HPE could be syndromic or non-syndromic. So in the syndromic forms, there are about approximately 18 to 25% of individuals have a pathogenic variant in single gene causing syndromic. So at least there are 25 different conditions which are or syndromes which are associated with HPE, and majority of these disorders are definitely rare. So coming to the autosomal dominant syndromes which are associated with Holoprosencephaly, the well-known are the Hall, Rubinstein-Chiavi, Kalman syndrome, Martin. These are other rare ones are Hartsfield, Steenfeld. And in the autosomal recessive form syndromes which are associated with HPE are pseudotrisomy 13, Smith-Lemli Opitz. Again, Smith-Lemli Opitz we have got the defect in the cholesterol metabolism. So again, it is the hypothesis. It helps that basically there is a problem with the steroid metabolism. Or the Meckel syndrome, then hydrocephalus syndrome, which is characterized by hydrocephalus, polydactyly and other anomalies, and facial eclipse and brachiolepidemia. These are some of the other syndromes. The autosomal dominant versus multifactorial could be associated with microtia, nausea, and other anomalies, and unknown mode of inheritance like Stevens-Gordon diseases, where the mode of inheritance is not yet clear. The non-syndromic, we can have autosomal dominant. These are the various genes including sonic hedgehog, that is one of the most common, that is SHS, ZIG2, 63, TGIF, GLI2. And other ones are also, these are various genes, DISC1, which are associated with the autosomal dominant non-syndromic forms of the HPE. So if you see the positive family history, in about SHS is responsible for about 30 to 40% cases, which is one of the most common, then ZIG2 is the second most common. The clinical manifestation of the non-syndromic, the phenotype of individual with pathogenic variants in gene is extremely variable. Even in the same family, there is a clinical variability. It could be from lobar to clinically normal. So in the majority of the individuals with HPE, a correlation exists between the facial anomalies and the gene involved type of pathogenic variant. So these are the facial findings in, as I said, the thing of the various non-syndromic form of this gene. And that include lobar HPE with cyclopia, with the closely spaced eyes, then pictured with the microcephaly, premental agenesis, and midline cleft lip and palate, and This is with closely spaced eyes, mid-face retrusion, and mild dwarfism. So we can have a variable in the same family. So coming to some just what about the xenotype-phenotype correlation? The various genes, deleted genes in Z2 mutations have been associated even at the most severe appear to have normally specific that includes a narrow forehead, upslanted palpebral features, large ears, and short nose. In the disc one, they may not have the corresponding brain or brain, but only facial features. And GLI2, some individuals with facial finding consistent with the HB spectrum and who have this thing also have been found to have hypopituitarism and may have additional extracranial anomalies, but no CNS findings consistent with HB. So when we see hypopituitarism, we can just say maybe this is the gene which is involved. So these are the genes assessed in X60 where the renal urinary anomalies are found. So these are the other genes which I will not go into too much of detail because it won't fascinate you. So these are FGF8, GAS1 and C1. So these are the various candidates which are being now proposed, gradually discovered as we are doing more sequencing and next generation sequencing has come up. It has been also proposed that it's basically multifactorial inheritance because various interact, but as I said, there is a environmental factor, diabetes, the alcohol intake, retinoic acids. So, and recently, as I said, that's abnormal steroid metabolism has been demonstrated in significant number of persons. So, these are the, it has been proposed that there is more of a multifactorial than purely genetic, but more of a, we are discovering more genes associated with HPE along with the environmental factors which are coexisting together. So, when we have some the child or proband who has come with holoprosencephaly or these findings, the prognosis mode we have to basically evaluate because diagnosis will give, lead to a proper prognosis mode of inheritance and genetic counseling. So we have to go back to obviously typical basic creative history to identify any possible environmental causes and physical examination finding that identify the findings that could establish the diagnosis of monogenic syndrome. Maybe as I said, Domin's therapy, Pariston, these are the syndromes that can be associated with HP. So we have to look for those syndromes if they are associated. With the detailed family history, with losses, neonatal deaths related with abnormal facial findings, developmental delay, obviously generation pedigree has to be drawn. Then the focused examination of the parents, because I told you there is the microforms of the HP which we can miss. So once you have seen and really see the single macular incisors and other findings that I mentioned earlier. So in the genetic testing, we can start with the karyotype as I said because chromosomal anomalies are observed in 25 to 50% of the cases. So, and then for some microscopic deletions, and if monogenic non-syndromic HP is confirmed or likely, then we can go for clinical exome or the complete panel for HPE genes. So, and CMU will pursue both with classical non-chromosomal or non-syndromic. By chromosome microarray pathogenic anomalies, maybe I detected up to 10% of the individuals with HPE. So, coming to the genetic counseling. It will be a little difficult because it's, there are multiple factors involved. So, if a proband with HP is found to have inherited or de novo chromosomal abnormality, a specific syndrome associated with HP or a pathogenic variant single gene, counseling for that is indicated. Maybe we have like sporadic condition or we have found some autosomal recessive condition like Chaveeva or so. Accordingly, we know the risk of recurrence would be 25% in subsequent pregnancy. Autosomal dominant depend on the whether the parents are affected or not, it's a de novo, then there are very less chances, but then yes, that slightly more than the general population because of the germ presence of the germline mutations or mutations. So, for probands with HP without a clear etiology, then recurrence in the family is likely to be low, but maybe as high as 50% because of the possibility of the, as I said, the germline mutacism for a pathogenic variant in one of the genes which are associated with non-syndromic HP. So, non-syndromic HP may be inherited in an autosomal dominant manner or may be the result of inherited or de novo chromosomal abnormality. So, when we are dealing with autosomal dominant non-syndromic HP, the parents of the proband, generally some individuals diagnosed with autosomal dominant form have an affected parent. So, however, a proband with autosomal dominant may have the disorder as a result of the de novo also. The proportion of the cases which are caused by new gene variants is 10 to 30% when it is depends on which gene is involved. So when sonic Muchong is involved, such as most of the cases which are de novo are 10 to 30% cases are de novo. In case of ZIP2, it is about 70 to 80% are de novo, and 60 about 10 to 20% of the de novo, and rest are like one of the parents would be affected in the rest of the cases. So, recommendation for the evaluation of parents of a child with non-syndromic HPE and no known family history include evaluation for the microforms of HPE. So, SIPs of the program is a typical, like we have found, as I already said, studies have identified that empiric risk to the SIPs of 20% for HPE, 15% for HPE microform, and 15% for the normal phenotype. If the parents are clinically unaffected and the family history is negative, the risk is low. So, what are the upstream? Every child of an individual with a pathogenic variant for an autosomal will have definitely 50% chance of inheriting. Although severely affected if they do not reproduce, individual mild forms and microforms may do so. So, they have a chance that 50% affected offsprings. The clinical symptoms and severity are variable. The phenotype may range from mild to severe. In the non-syndromic with chromosomal abnormality, the parents of a proband, parents of a child with a numeric chromosome abnormality like trisomy or whatever are expected to be chromosomally and phenotypically normal. So, generally, somebody is having the child proband is having trisomy or triploidy. So, we expect that parents to be normal because they would not be feasible to have a normal life with that. So, whenever a child is structural, maybe unbalanced chromosome rearrangement due to deletion or duplication, are at risk of having a balanced chromosomal rearrangement. So, generally, somebody child having deletion or duplication in one of the chromosomes, their parents can have balanced chromosomal rearrangement, and they should be offered with the chromosomal analysis because of then with subsequent pregnancy we can predict the risk. So, and what are the SIPs of the proband? SIP to a child with numeric chromosomal abnormality has a slightly increased risk, and the risk to the SIP for a child is structural chromosomal abnormality depends on the chromosome stage of the parent. So, in case we have found the structural chromosome abnormality in the proband, like any duplication or deletion, so in that case, we have to offer parental karyotype should be done, and the risk to the SIPs depends on the status of the parents. If neither parents has a structural arrangement, the risk to SIPs is negligible. And if a parent has a balanced structural rearrangement, the risk is increased and depends on the specific rearrangement and possible other variables. Offspring generally individual HPE and chromosome rearrangement are unlikely to reproduce. So other family members of the proband, the risk to the other family members depends on the status of the proband's parents. If a parent has a chromosomal rearrangement, his or her family members are at risk and can be offered chromosomal analysis. So, in the prenatal testing, high risk pregnancies to fetal ultrasound should be done, and then LOR forms are generally detectable by 16 weeks. Fetal MRI is to delineate the anatomy in a better manner. Then molecular genetic testing, karyotype and CMA depending on what we are suspecting, any other associated findings. So, ideally, we have detected, then these tests can be offered to them. Low risk pregnancies, when HPE is found on the routine prenatal ultrasound, examination of fetus not known to be at increase of the high maybe ultrasound to determine the presence of additional structural anomalies is indicated. Then fetal karyotype should be done. CMA if the karyotype is normal, and the sequence analysis of the following genes. In basically, if we can do nowadays with the presence of the next sequencing, we are going for the panels, and these all can be covered in one go. So, but otherwise, if you have to choose, then ideally these are the common. Like I said, 30 to 40% is of course sonic HR gene, SHH. So, this should be tested first, followed by ZIP2 and so on. Management about the associated findings. Like clinical and palate, we have to prepare that. Presence of the hydrocortisone may require shunting. If associated hypopatriotism is there, growth efficiency, then charting, and then the growth hormone supplementation should be done. And oral feeding and swallowing, we have to take care of that part by calorie intake, oral motor skills, occupational speech evaluation should be done time to time. So, other, as I said, for seizures, we have to give anti-epileptic drugs, and for this, maybe at times the feeding difficulties may be very severe, which may require gastrostomy tube placement and nasal thunderglycation. And thinking of that, what we do for others, like thinking of the feeds and upright positioning, may help these patients. So, and for hydrocephalus placement of the BP shunt may be necessary. And in older children, surgical repair of the cleft and palate may be indicated. And major aspect is basically always in the genetic disorder is the treatment, support, and the counseling of the parents. Thank you. If there are any questions or anything which I can